So this case is about managing cryptococcal infection. And we know the guidelines like how to treat cryptococcal infection. And we also witnessed increase in the case of cryptococcal disease, especially in non-HIV and non-transplant host. So this is an area which is, I think, we need to study a lot to develop future treatment perspectives for this treatment of non-HIV, non-transplant group. But by and large, like even in HIV infected patients or non-HIV infected patients, the treatment of cryptococcal infection is really challenging. And there are several challenges from financial challenges to the availability of the drug and toxicities of the drug, right? So very expensive drug because you have to use liposomal amphotericin B and 5-flucytosine. Both the medicines are very expensive. At many places, the 5-flucytosine is not available. So that is another important challenges. And when you combine two toxic drugs, one is amphotericin B and second is 5-flucytosine, you may end up with a variety of toxicities while managing these patients. So this is another big challenge. The, the, the important challenge that many times like we fail to address would be like need for hospitalization, need for central line placement, and many patients they die because of the central line associated bloodstream infections rather than the infection with the cryptococcal or the fungal infections. So I think this is also a big challenge. The management of raised intracranial pressure is very important for clinicians because the in-hospital mortality related to the cryptococcal infection is mainly because of uncontrolled raised intracranial pressure. So the cause of death would be the raised ICP which is there and which is not properly managed, which may kill your patient. So this is another important challenge. To achieve a sterile CSF, especially in non-HIV, non-transplant hosts. So you can say like those patients who has cryptococcal infection without any immune defect, the managing such patients are more challenging. To achieve a sterile CSF would be a big challenge. And these are the patients who requires a very prolonged induction therapy as well as the prolonged the secondary prophylaxis or the maintenance therapy. So with this background, like I'll start my case. This is a very old case, but very interesting case. So this gentleman is 28 years male, 75 kg, residing in my state, Gujarat state, which is in the western part of India. And he was previously healthy, no past history of any medical illness. And he works in the rice mill. He presented to a neurologist with headache, tingling and numbness of the right upper limb. So he has some focal neurological deficit along with the headache. And he was evaluated by the neurologist. The CSF examination was normal. The MRI brain contrast study was normal. The MR venogram was normal. And he was negative for hepatitis B and the HIV. And the rest of the biochemical tests, which generally we perform for the evaluation, were negative, normal. So the neurologist prescribed a painkiller and the antidepressant without significant improvement. So he continue to give the symptoms, and he has no benefit. So with these persistent symptoms, he again presented back to the neurology clinic. So repeat CSF was performed within a 2 weeks time. The protein was normal, that was 37 milligrams. The sugar was 41, so it is slightly lower than the expected value. So random blood sugar was 110, so it is less than 50%. The CSF showed 15 cells, all were lymphocytes, and the microbiologist also reported budding capsulated yeast cells that was seen in India ink preparation. So patient was started on fluconazole 200 milligram tablet twice a day with this CSF report. The follow-up CSF after 3 weeks, the protein was 56.7 milligrams, so protein has increased. The sugar remains same, but RBS was now 124, so there is further decrease into the sugar, in the CSF sugar. Total cells were 4, and there is a good clinical response. So his symptoms of headache and tingling and numbness has improved. So fluconazole, neurologist continued fluconazole for 10 weeks time. So what is the best strategy to manage this situation? This is a question to the audience. So do you agree with the current therapy as patient has clinical response? The CSF showed the little bit increase in the protein, but there is a decrease in the cells count from 15 to 4, and patient has good clinical response. So will you continue the therapy as prescribed? Or you'd like to give amphotericin B followed by fluconazole consolidation or standard therapy M4 plus 5-flucytosine? So almost 75% of the audience would like to change the therapy despite clinical response. Great. Right, so I agree with the audience. So even though like patient has clinical response, but we have to remember here that patient is healthy patient do not have any comorbidities, patient was negative for human immunodeficiency virus infection. So I mean, to get a cryptococcal meningitis is relatively uncommon in immunocompetent otherwise healthy host. Here we do not know the species because culture was not done, so we do not know whether it is a Cryptococcus neoformans or whether it is a Cryptococcus gettii. But how do we treat cryptococcal infections? So we do have, I mean, good information from HIV studies as well as from the non-HIV host. So from HIV studies, like it's very clear that when you combine two drugs, that is amphotericin B plus 5-flucytosine, the early fungicidal activity is the best with the when you combine amphotericin B plus 5-flucytosine, right? And this early fungicidal activity is translated into the probability of survival, right? So when you clear the CSF from the cryptococcal infections early, it is associated with the clinical benefit also. So combination therapy is the treatment of choice, or treatment should be given to the patients. So I agree with the audience. So there are other studies, like they looked at the liposomal amphotericin B alone or in combination with 5-flucytosine in non-HIV cryptococcal meningitis. So that was the previous study was HIV host, and this study was carried out in non-HIV infected hosts. So what they found, like even though like we know that there is early fungicidal activity, but in this study, like in non-HIV host, the combination therapy showed a better prognosis than the liposomal amphotericin B, that is 6% versus 11%. But there is no significant difference in the treatment outcome. And when they extended the observation up to 30 days, then there is clearly no significant benefit. So here the amphotericin B monotherapy, that is liposomal, was equally found to be effective in non-HIV host. So next question to the audience. So which of the following is not required for the management of this patient? Cryptococcal drug susceptibility testing, cryptococcal antigen titer, opening pressure and CSF lactate, workup to rule out TB co-infection, and workup for immunodeficiency disorder. So which of the following is not required? Need some more voting, 38% says voted. Okay, so 55% feel that, I mean, the drug susceptibility is not required. So any would like to argument why they do not want a cryptococcal in vitro drug susceptibility testing for the treatment of this cryptococcal meningitis? Anyone who has voted for this? Why it is not required? Let us understand this. So this is a, I mean, good study published recently, before 2 years. So what, I mean, they did, like, I mean, they look at the antifungal drug susceptibility testing of the baseline isolates of these cryptococcal neoformans. And in this study, like, there were 3 arms. The deoxycholate amphotericin B for 4 weeks, deoxycholate plus 5-flucytosine 2 weeks, deoxycholate plus fluconazole 2 weeks. So in all amphotericin, when they looked at the baseline amphotericin drug susceptibility and divided into 2 groups, amphotericin B MIC less than 0.512 and more than 0.512, they found no difference. In flucytosine arm, when patients were receiving amphotericin plus 5-flucytosine, and they divided the isolate into the 2 major groups, flucytosine MIC less than 4 and more than 4, and they found, though there is a difference, but they do not found any the difference in the clinical outcome. The p-value was just 0.13. Similarly, in the fluconazole recipient group, when the fluconazole MIC is more than and less than 8, even it did not affected the outcome in this group of the patients, right? And the fluconazole MIC in M4 plus fluconazole group, similarly, like they did not find any significant difference. So the study concluded that the baseline antifungal susceptibility testing plays a no role in routine clinical management of first episodes of cryptococcal meningitis. So I mean, if we are not requesting drug susceptibility testing, I think it should be okay. The another things that we asked in the question that I mean, uh, should we look for the opening pressure, CSF lactate in this group of the patients and the cryptococcal antigen titer. So CSF lactate has been found to be one of the additional important prognostic markers in the cryptococcal meningitis treatment. And these are the data which has come up from, they looked into from this sertraline study, that is AstroCM study. And they looked at the baseline the CSF lactate, and they divided CSF lactate into the three group according to the CSF lactate level less than 3, 3.125 and more than 5 millimole per liter. And what they found that the patient whose CSF lactate was more than 5 millimole per liter, they had a higher CSF white cell count, lower CSF glucose, high CSF opening pressure. The Glasgow Coma Score was less than 15 and baseline seizures. So this is, I think, one of the additional important prognostic markers apart from the CSF cryptococcal antigen titer, the opening pressure, the altered sensorium on presentation. So we can also use probably the CSF lactate as one of the prognostic markers in assessment of our patient with cryptococcal meningitis. And in multivariate analysis, when they looked at all these important the factors which can influence the outcome, like baseline seizures, opening pressure, and the quantitative CSF culture, the high baseline CSF lactate continued to be a threefold higher risk for mortality at 2 weeks as compared to CSF lactate less than 3. So this is, I think, one of the very important prognostic markers in cryptococcal meningitis. So coming back to our patient, patient has received fluconazole 200 milligram twice a day for 8 weeks. So after 2 months of completion of treatment, the patient was readmitted with the severe headache, altered sensorium, fever, cough, and breathlessness. And this was his X-ray chest on admission to the hospital. The repeat CSF examination was done by the neurologist. Now protein further increases to 156 milligram. There is further decrease in the sugar, 120 to 30. And now cells which were 4 increases to 112, 90% lymphocyte, and India showed capsulated yeast. So now neurologist has changed the treatment to ceftriaxone and deoxycholate amphotericin B 1 milligram per kilogram and continued the supportive care. But there is a progressive clinical deterioration over the next 1 week, and patient becomes breathless, intubated, and now patient is on mechanical ventilator. And you can see within a 1 week time there is a rapid worsening of the X-ray chest, and you can see the CT scan, corresponding CT scan, multiple patchy opacities distributed in both the lung fields. So bronchoscopy was performed, and the BAL showed plenty of capsulated yeast cells, which is suggestive of the cryptococci. And at this time point, they ask our opinion, like what to do with this patient. So now patient is on 1 week amphotericin B deoxycholate 1 milligram per kg. The BAL showed multiple yeast. The CSF shows further worsening. So the reports which were available to us when we start assessment, the cryptococcal culture came positive with the Cryptococcus neoformans. Biochemistry was normal except for the hypokalemia related to amphotericin B therapy. So we asked for the further reports. We asked for the cryptococcal antigen titer into the CSF just to look at the titer, and which was low, like 1:64. Repeat HIV testing was done because patient was otherwise immunocompetent. Patient do not have any past history of medical illness, and the first HIV was negative. So repeat HIV testing was done, which was also negative. We looked for the CD4 cell count. It was 8.87%, 153. So treatment changed to the deoxycholate plus 5-flucytosine to this patient. The patient tolerated this treatment well, though there was a renal injury and requires amphotericin B drug interruptions, requires daily potassium supplementation, but patient has good clinical response. Patient was extubated after 8 days. The sensorium improved, and now he started following verbal command. He requires repeated lumbar taps to control raised intracranial pressure, and the repeat CSF culture which was carried out was positive after 2 weeks. So patient was on 2 weeks of amphotericin B plus 5-flucytosine, and we prolonged the induction therapy for 8 weeks. And repeat CSF culture was sent after that. And consolidation with fluconazole plus 5-flucytosine for further 2 weeks. And this was a follow-up X-ray chase which showed a significant improvement. So in this patient, we have prolonged the induction therapy to 8 weeks, and at the end of the 8 weeks, we have stepped down to fluconazole plus 5-flucytosine, as he has the 1 bottle of 5-flucytosine available. So we do not want to take chance because he was difficult to treat and he has disseminated disease. And we sent a culture at the end of 8 weeks. So now questions to the audience. How long do you intended to continue the induction therapy in non-HIV, non-transplant cryptococcal infections? 2 weeks, 4 to 6 weeks, 8 weeks, or till patient achieves sterile CSF? So don't give my answer. I have given for 8 weeks, but I mean, it may not be a true or the correct answer. It was a desperate prolongation of the induction therapy. So the 62% audience feels that they will continue the induction therapy till patients achieve sterile CSF, right? So let us see like whether I mean this is true, or I mean we need to give we can change the induction therapy before the patient achieves sterile CSF. So let me take an help from a very old AIDS clinical trial group, the first the randomized treatment trial. This was conducted in HIV infected patients long back. I think it is in 1997, so very old study which was published in NEJM. And in this study, like their step one, that is induction therapy, was deoxycholate plus 5-flucytosine or deoxycholate alone for 2 weeks. So this was a standard induction therapy that they have used in HIV infected patients. And the step two, that was a consolidation by either fluconazole or itraconazole. And at the end of 2 weeks of completion of either monotherapy or combining 5-flucytosine plus deoxycholate, the culture was negative in 60% of the patients in combination arm and 51% of those who received monotherapy alone. So 40% of a patient who had 5-flucytosine plus deoxycholate have positive culture at the end of 2 weeks, and half of the patient had positive culture at the end of 2 weeks in monotherapy arm. But they changed the therapy from induction to the consolidation therapy, and at the end of 10 weeks, the culture was negative in 72% of the fluconazole arm and 60% of the itraconazole arm. That means that there is increment in the patient who received the consolidation with fluconazole more as compared to the itraconazole. And look at the mortality. Look at the actual outcome where we intended. The 5.5% mortality in both the groups, so monotherapy as well as the combination therapy, mortality is equal. And in step two, that is consolidation, at the end of completion of consolidation, mortality is 4%. Right? So there is no difference in mortality, even though the cryptococcal CSF culture was not sterile. So patients fails to achieve sterile culture. So now question comes like, how long should we treat crypto in non-HIV, non-transplant hosts? So this is again very tricky situation. So no correct answer. So we need to look into the various, the case publications or the small case series, because we do not have a large clinical trials just like the cryptococcal infections in HIV infected patients. The main reason is that this is heterogeneous group. So these are apparently normal hosts. It includes the either hematological malignancies to cirrhotic patients, so patient with end-stage liver disease, and there is no single therapeutics regimen you can use for in this trial. So in general, like I mean, the liposomal amphotericin, this is from the current the cryptococcal guideline which is under development. So still, it is for a public consultation. So this current guideline says that liposomal amphotericin B 3 to 4 milligram plus 5-flucytosine in standard dosage for minimum 2 weeks, right? But consider extension of induction therapy if you are treating Cryptococcus getii CNS infection. The reason is that getii produces more granuloma formation, so the mass lesion is much more with the getii as compared to the neoformans. So in case of getii, you may extend the induction therapy to 4 to 6 weeks. Induction therapy may be extended in patient with persistently positive culture. So there is no strong recommendation. You may extend, just like in our case where we presented that we have extended to the 8 weeks. So you may extend and in a patient who has positive culture and or the persistent symptoms at the end of 2 weeks of time. So these are the alternate therapy. You can use the amphotericin B lipid complex plus 5-flucytosine or deoxycholate plus 5-flucytosine or fluconazole plus 5-flucytosine. These are the alternative regimen for the treatment of crypto in non-HIV, non-transplant setting. So how should we treat like consolidation after induction therapy? Consolidation is just like the HIV host, that is fluconazole 400 to 800 milligram for 8 weeks. Or you can use voriconazole, posaconazole or isavuconazole in place of fluconazole, and maintenance is fluconazole for at least 12 months. Right, and the alternative antifungal agents would be vori, posa, isavuconazole or itraconazole. So case continues. So case is still not over. The CSF culture that we drawn on the week 8 was sterile. So we continued fluconazole high dose for 3 months. So we have extended the consolidation, and after 3 months, fluconazole was reduced to 400 milligram, and he was continued with the fluconazole 200 milligram per day for his rest of the life. His repeat HIV test was negative, but he remained in our follow-up and developed progressive multifocal leukoencephalopathy after 7 years of development of cryptococcal meningitis before he died. And this where is the serial CD4 count. This was a baseline CD4 count. After 9 months of first episodes of cryptococcal meningitis, his CD4 were 210, 8%, and at the end of 12 months, it remains the same. So this patient has idiopathic CD4 lymphocytopenia, and that was the cause for his two opportunistic infection. One is cryptococcal infection, and second was progressive multifocal leukoencephalopathy. So let us review some of the literatures pertaining to the non-HIV, non-transplant host. So this is a study from the US, the cryptococcal meningitis. They reported increased mortality in non-HIV, non-transplant group. And in this study, like they compared with the HIV host to the non-HIV, non-transplant, and you can see that there will be more the WBC count into the non-HIV, non-transplant group as compared to the HIV. The CSF sugar is much lower in non-HIV, non-transplant group, and the protein is elevated. So all these features suggest that as compared to HIV, where I mean we generally expect cryptomeningitis with less than 100 CD4 count, so they are severely immunocompromised. But in non-HIV, non-transplant, they mount a severe inflammation, intracranial inflammation as compared to the HIV. The opening pressure in both the group were the same, but altered mental status was very common and very high in non-HIV, non-transplant group. And look at the mortality, 8% versus 41%, and 1 year mortality 12% versus 41%. So obviously, like this non-HIV, non-transplant group has higher intracranial inflammations, and the prognosis is poor as compared to HIV-infected patients. And that's the probably reason that we need to give a prolonged induction as well as the maintenance therapy. Another study from the Brazil, and they reported 20% mortality, and they mentioned that aggressive intracranial pressure management is required when you treat non-HIV, non-transplant group. And they also recommend amphotericin B in combination with either fluconazole or 5-flucytosine for the treatment of non-HIV, non-transplant group. So now reviewing the cryptococcal infections into the idiopathic CD4 lymphocytopenia patients. So this is a large series which was published in the Medicine in 2007. And here the median age was 41 years. The CNS cryptococcosis was in 75%, pulmonary 11%, and bone disease in 8%. The WBC count median was 59, glucose was low, protein was elevated. Looks like similar to our patient's picture. The CD4 count at the diagnosis was 82, and this is a response. And they use a variety of regimens for induction of cryptococcal meningitis, from amphotericin monotherapy to amphotericin B, flucytosine, fluconazole, and so on. Right, so that's the reason that the response rate is not that great. That different regimen was used. So just to take home message from this case that we have treated long back, the cryptococcosis in non-HIV, non-transplant host is difficult to treat because these are the heterogeneous group and we do not know the exact immune defect, and they may have some additional immune defect also. They generally require a prolonged therapy, especially when you are treating with Cryptococcus gatii. There will be a higher inflammation into the CSF as compared to the HIV host, and they may require a prolonged secondary prophylaxis to prevent recurrence, because recurrence is very high. In HIV, we know when we are going to stop secondary prophylaxis. But in this group of the patients where we do not know the exact immune defect, so probably they may require very prolonged or probably lifelong secondary maintenance therapy. Thank you very much for the patience.